everyone. I'm so happy to be here. Like Laura mentioned, I'm Jaclyn Ross. I am located in Chicago. I split my time right now between private practice with a specialty in premenstrual disorders and also spend time doing research at UIC on particularly right now on premenstrual exacerbation of suicidality. But kind of across the board on evidence-based assessment and treatment of premenstrual disorders. So we're going to start broad by talking about what is PMDD. So PMDD is a cyclical hormone-based disorder with symptoms arising during the premenstrual or luteal phase of the menstrual cycle and lasting until the onset of menstrual flow. So we know that PMDD affects an estimated 5.5% of ovulating people. And PMDD is a severe negative reaction in the brain to this natural rise and fall of estrogen and progesterone. And we'll talk a little more about what causes that in a minute. So in terms of the symptoms of PMDD, first, there's 4 core emotional symptoms of PMDD. The first being mood or emotional changes. This includes mood swings, feeling suddenly very sad or tearful, or increased sensitivity to rejection that can feel more sensitive to perceived criticism or to feeling rejected by others. Irritability, anger, or increased interpersonal conflict. Depressed mood, feelings of hopelessness and feeling worthless or guilty. And anxiety, tension, or feelings of being keyed up or on edge. Some other common symptoms include decreased interest in your usual activities. So that might mean a loss of interest in your work or your school or your friends or your hobbies. It includes difficulty concentrating or focusing or thinking, or sometimes called brain fog. It might include tiredness or fatigue, changes in appetite or food cravings, overeating, even binge eating. It may include hypersomnia, so that's kind of that excessive sleepiness, or insomnia, which is the trouble falling or staying asleep. You may feel overwhelmed or out of control. And it often includes physical symptoms such as breast tenderness or swelling, joint or muscle pain, or bloating or weight gain. So in order to be diagnosed with PMDD, you must experience at least 5 of these symptoms that I've listed, and at least one of them needs to come from that core emotional symptom list. So that's those 4 bulleted above. You need to have at least one of those to be diagnosed with PMDD. And these symptoms occur during the week or 2 before menstruation and go away within a few days after bleeding begins. So what causes, one other thing actually that I'd like to quickly mention about symptoms of PMDD. As I said, it occurs in the week to 2 weeks before menstruation starts, and it's important to note that there's always going to be a symptom-free window in between your period and ovulation. So maybe within a few days of your period starting, or at least by the time it ends, between that time and when you ovulate, you should not experience any symptoms. These symptoms should really kind of clear out during that time so that there's this clear kind of off-on pattern in your symptoms. So what causes PMDD? First, we know that PMDD is a suspected hormone sensitivity disorder in the brain. So we want people to understand this as I have a hormone sensitive brain. And studies suggest that among women and AFAB assigned female at birth individuals with PMDD, brain circuits involved in emotional response may activate differently compared to those without PMDD. So in 1998, researchers at the National Institutes of Health found that those with PMDD are more sensitive to normal changes in the sex hormones, estrogen and progesterone. And later in 2017, they found that this might be due to differences in the genes that process these sex hormones. So it's not that there's anything wrong with the levels of your estrogen and progesterone, right? There's nothing wrong with the reproductive hormones themselves, right? It's that your brain, your central nervous system, is more sensitive to these normal changes and fluctuations in estrogen and progesterone that happen over the course of the reproductive cycle. And there are many ongoing areas of research into what exactly is causing PMDD. And ultimately, it's most likely that PMDD results from a combination of factors. I do want to just draw everyone's attention to a nice YouTube video here in case you're interested on different types of PMDD. So there are more than one type. So to understand kind of what causes or prompts PMDD, first there's this question of what can trigger it to start. And we don't have a definitive answer yet as to why this happens or what the initial trigger is to PMDD developing or starting. While some people do find that PMDD occurs from their first period, right, when they're maybe 12, 13, for others, it can and does begin at a different stage in their reproductive lifetime. It's also important to note that your symptoms can also worsen or change over time, or kind of in tandem with other reproductive events such as pregnancy, birth, miscarriage, or perimenopause. And again, the reason for this is not fully understood yet. We often hear from patients a myriad of different experiences. What we do know is that it's most likely that stress contributes. Women and AFAB individuals with PMDD often report higher levels of stress, including perceived stress. So this is the feelings or thoughts that someone has about how much stress they're under in a given time, as well as work stress, right? How much stress they're experiencing through employment. And these stressors, in combination with potential alterations in the body's stress response systems, may contribute to PMDD beginning. It's also worth noting that many, but not all people with PMDD also have a history of trauma exposure, which may contribute to the development of PMDD over time. And we hope that future research provides more answers to help understand the full etiology of PMDD and PME so that accurate support and treatment can be given. So we can think of kind of 5 interwoven pieces that serve as vulnerability factors or causes for PMDD. So one is genetic susceptibility. Another is these abnormal effects of the progesterone metabolite allopregnanolone or allo in the GABA system. Another is abnormal effects of estrogen and progesterone on serotonin and other neurotransmitters. So that's your reproductive hormones affecting kind of what's going on in your brain. Possible brain structural and functional differences, and possible involvement of the hypothalamic pituitary adrenal or HPA axis or the HPG axis. And this can have to do with trauma and resiliency and inflammation. So we think that all of these different areas are kind of interacting to increase risk for development of PMDD. So we often hear this question, this self-doubt of, is PMDD real, right? And I hope you know that I'll tell you, of course, PMDD is real, right? We have really strong evidence at this point that this is a very real and serious phenomenon that affects a lot of people across the world, right? First, there's gene complex, there's research kind of establishing dysregulation in the expression of a gene complex, right? So we're actually starting to get evidence of this kind of cellular biological cause for this abnormal brain sensitivity. So what they found is this dysregulated expression in this one gene complex that kind of causes this irregular response to estrogen and progesterone. Also, this has been in the DSM-5 and the ICD-10 since 2013. So the American at least American and international psychological and psychiatric organizations and gynecological organizations are recognizing this as a real and distressing and impairing disorder. Another question that also often comes up is, how do we know that PMDD isn't a hormonal imbalance, right? And as I mentioned earlier, what we know is that it's not a hormonal imbalance. It's that your brain is sensitive to the normal hormone changes across the cycle. And we know this because there are many studies that are finding no difference between people with and without PMDD in their levels of hormones. So when we pit these two against each other, we see people with and without PMDD have similar levels of estrogen and progesterone. And even when scientists experimentally control hormone levels to recreate kind of a normal luteal phase of the menstrual cycle, that's that kind of window leading that week to 2 weeks leading up to menstrual bleeding, people with PMDD show symptoms, whereas controls do not. So once again, when we kind of create similar levels of hormones across all people, people with PMDD are having symptoms while others are not. There's also very strong experimental studies showing normal metabolism of hormones known to trigger symptoms. All of this lending support to the notion that this is not a problem or an imbalance with your reproductive hormones, but rather a sensitivity of your brain to these normal changes in hormones across the cycle. So how is PMDD diagnosed? PMDD cannot be diagnosed via blood, hormone, or saliva tests. So often we get this question of, will there ever be a blood test? And work is ongoing. Scientists believe that PMDD is not an abnormal level of anything in the blood, but instead an abnormal reaction of brain tissue. Like I said, it's this abnormal brain response. And so the relevant differences may not be detectable in the blood from a patient's arm. So so far, we don't have any consistent biomarkers identified. So the only way to currently get a diagnosis for PMDD is by tracking your symptoms on a daily basis for a span of 2 or more menstrual cycles. And this is really important because what we do know is that if you just kind of report your symptoms looking back over the past year and trying to remember, that ends up not matching up with very reliably with daily ratings over 2 months. So that those daily ratings of symptoms are quite important. And that's why kind of the larger associations, such as, I'm the American here, but such as the American Psychological Association, they do require those 2 months of daily ratings in order for you to be given a formal diagnosis. So we have some resources here, and Laura can speak more to this if there are additional questions, but we do have some resources here for doing that daily ratings, doing those daily ratings of symptoms. So first, on the IAPMD website, to this link, there is a PDF version. If you're more of a pen and paper person, that's for the daily record of severity of problems. That's the gold standard measure for daily ratings of PMDD symptoms. So you can use that. And then there are also some great iPhone apps that have been developed, not just iPhone, smartphone apps that have been developed to track these symptoms as well. 2 really common ones, and I believe both are mentioned on the website, are Me versus PMDD and Prementrix. Okay. So which kind of doctor can diagnose PMDD? A lot of different doctors, right? A general physician, a GP, a gynecologist, a psychologist, a psychiatrist. All of those doctors could diagnose you with PMDD. What really matters is their level of knowledge, training, and education, right? You want to make sure that you are working with a doctor who is encouraging you to do 2 months of daily ratings and then is able to score those in a thoughtful way to determine if you're kind of meeting this kind of diagnostic criteria for PMDD in terms of how your symptoms change cyclically across the reproductive cycle. So in sum, I'd say any doctor can do this. It's just about finding the one with the right knowledge. Often we get this question of why is it so hard to find a doctor who knows about PMDD? And it is really, really hard. And the problem is that many medical doctors and psychologists, therapists do not know that PMDD or PME exist. They also don't know how to treat them or which specialty should treat them. And this is for a lot of reasons. One, the diagnosis of PMDD just became official in 2013, so that's fairly recently. And in that time, at least in the US, national organizations in charge of psychiatry and gynecology and psychology still aren't requiring that their students learn about PMDD as part of their training, right? So we have a lot of kind of healthcare professionals out there who don't have this knowledge. So it does require a little extra kind of searching and advocacy for yourself to find a doctor who is knowledgeable enough to be able to kind of accurately diagnose you and recommend evidence-based treatments. And we hope that today's webinar can also be a resource in that too, in making you a really informed consumer of the treatment that you pursue. So Some common questions: what can I do if my doctor does not acknowledge that PMDD is a real condition? This is really hard. And I think from an emotional perspective, I think it's important to kind of self-validate and remind yourself of this kind of discussion today about the fact that PMDD is very much real and very serious and distressing and impairing often. And beyond that, it's direct them to the IAPMD website, right? Share with them an article, share with them other resources kind of available, such as the up-to-date treatment guidelines. We have a link to those on our website too, right? And if all else fails, find a doctor who does acknowledge that it's a real condition. And like I said, being prepared for doctor's appointments, whether it's by coming with articles from our website, or also by, if you look at the iapmd.org toolkit section of the website, there's an appointment sheet that kind of gives you a way to prepare in advance of your appointment of what are the things I want to talk about today, what have I already tried, etc. So let's talk a bit about the treatment options for PMDD. So it's important to note that there is no single option that works for all of those living with PMDD. So you're going to want to work with your healthcare provider to find the best treatment option for you, maybe some combination of treatment options. And many people find it's important to use a combination of several treatment options in order to get the most relief. Some treatments may lessen symptoms or improve them really greatly, while others may have no effect or even worsen symptoms over time. So you'll always want to consult with your medical team throughout this process and before starting or stopping any medications or treatments. There are several options for evidence-based treatment that are currently prescribed to manage symptoms of PMDD. Some have been proven to be effective, and others have not. So we'll talk about kind of the best options with the strongest evidence base. A comprehensive patient guide to treatment is launching soon on the IAPMD website. So you can sign up for the IAPMD newsletter to make sure you get notified when that comes. So broadly, the treatment options for PMDD are lifestyle changes. We'll talk a little about that. SSRIs, also known as antidepressants. Oral birth control pills. This is often a combination of ethinyl estradiol and drospirenone on a continuous cycle. Talk a little about that. Hormone therapy or cycle suppression. This is more common in the UK. Chemical menopause, also known as GnRHa. We'll talk a little about that. And surgery. This is often ovary removal and sometimes full hysterectomy in addition. So I'll speak briefly about lifestyle changes, just to say a healthy lifestyle improves general mental and physical health. However, only low-quality evidence is available linking these outcomes to premenstrual symptoms, and the findings are mixed. So lifestyle changes alone may be more appropriate for managing mild premenstrual symptoms than for PMDD, but they're important for everyone in terms of supporting overall health. So we know that optimizing sleep, reducing stress, and increasing exercise and movement are all recommended. Lifestyle changes are the first line of defense in trying to minimize symptoms of any mental health disorder. So that includes PMDD. Getting plenty of sleep and exercise while eating a diet that's rich in plant-based proteins, complex carbohydrates, fruits and vegetables, that's the foundation of any treatment plan. While keeping to a healthy diet and maintaining self-care can be challenging during the luteal phase because of decreased energy, brain fog, what have you, depressed mood. Reducing stress and getting enough sleep can also be vital in surviving the cycle. So for those with milder symptoms, we often recommend that these interventions are tried before pharmacological interventions. So even though solid evidence is lacking, clinicians generally recommend that patients with PMDD decrease or eliminate the intake of caffeine, alcohol, nicotine, and refined sugar. Take that as for what you will. We need more research in this area on kind of psychotherapies that are most effective in treating premenstrual symptoms. There is some evidence that cognitive behavioral therapy or CBT can work well in treating premenstrual symptoms. I think we need more evidence on other interventions, maybe that account for premenstrual symptoms more so, maybe something like dialectical behavioral therapy, DBT. We need more research to understand kind of which psychological interventions work the best in treating premenstrual symptoms. SSRIs. I want to start by acknowledging that I think a lot of people, at least in my practice, I often meet people for the first time who tell me that they feel like doctors are just throwing antidepressants at them. And of course, that can feel kind of frustrating and invalidating. What I want to explain is that SSRIs are a class of medication that used to commonly be called antidepressants. However, in more recent times, many have moved away from this description due to it not being entirely accurate, because these drugs actually work to treat a variety of ailments and seem to work just as well for anxiety and irritability as they do for depression. And they actually work more quickly in PMDD than they do in anxiety and in depressive disorders. So they actually improve symptoms more than a placebo pill after just 24 hours of use. So SSRIs seem to have this kind of fast-acting effect on our PMDD symptoms. This form of treatment has been shown to improve irritability, depressed mood, kind of mood lability, those swings, anxiety, and some physical symptoms such as bloating and breast tenderness. So in PMDD, SSRIs work about 60% of the time, which is a better percentage of effectiveness in PMDD than when the same medications are used to treat depression, which is pretty striking. Although it's unknown exactly how SSRIs work for PMDD, it is likely that these medications work by either increasing availability of serotonin in the brain or by increasing the conversion of progesterone to neurosteroids. So the hormones in the brain whose fluctuations play an important role in various female conditions, including PMDD. And like with any treatment, individual differences in treatment response are important to acknowledge, right? One size does not fit all. It does not work for everyone. So when we say SSRIs work for PMDD, what we really mean is that SSRIs work better than a sugar pill, right? A placebo pill for about 60% of people with PMDD. We definitely don't intend to imply that SSRIs work for all people with PMDD, but we also don't want to downplay the importance of SSRIs for PMDD, since they seem to be the best first-line tool we have for treating PMDD currently. The next line treatment, we'd say oral contraceptives are actually another first-line treatment option for PMDD. So the pill contains two forms of female hormones that include ethinyl estradiol, that's the estrogen, and drospirenone, which is the progestin or the synthetic progesterone. So drospirenone-containing oral birth control pills are a frontline treatment for PMDD, but that drospirenone is an important component. Not all birth control pills contain drospirenone. Some pills may contain only progestin. They do make a drospirenone-only version of oral birth control called SLIND, I think, in the US at least. When taken daily, these hormones travel through the bloodstream to the pituitary gland to prevent the release of LH and FSH, which in turn prevents the growth of an egg at ovulation. So really what it's doing is it's suppressing ovulation. And drospirenone is a progestin. Like I said, this is kind of a critical ingredient in the oral birth control. And what's special about drospirenone is that it has a longer half-life, which means that it kind of smooths out those hormone fluctuations, maybe better than other progestins. In order to reduce or eliminate the hormonal fluctuations that trigger PMDD, you should start with a drospirenone-containing oral birth control, such as Yaz, and you should use it on a 24/4 schedule. So 24/4 would mean 24 active pills, 4 placebo pills, or on a continuous dosing schedule. So that would mean you'd skip the inactive pills entirely and just start a new pack. However, on average, SSRIs do appear to perform somewhat better than drospirenone-containing pills for treating PMDD. So although birth control pills might be more appealing to some because they impact the reproductive system and avoid having to confront maybe certain social stigmas or things like that that can sometimes be associated with taking SSRIs, keep in mind that SSRIs do address the biological mechanisms of PMDD symptoms. Yes. Cycle suppression using HRT. So this is a hormone therapy. This is used primarily in the UK. So I'm not going to speak as much to this one as the resident kind of American here, but this is another option that's more available for those in the UK. I can speak more to chemical menopause. Chemical menopause is a term used to describe the temporary and reversible menopausal state created with the use of a medication called GnRHa, which is a type of drug which acts on the pituitary gland in the brain to suppress ovulation and production of ovarian hormones. So by fully suppressing the menstrual cycle, by shutting down the ovaries, so it eliminates the fluctuations which lead to PMDD symptoms. So GnRHa is used when you have not found the relief of symptoms by using less invasive treatments. So this is typically when someone has tried SSRIs, has tried birth control. Now we're looking at something like GnRHa. The important thing to note with GnRHa is first, I know it can sound kind of intimidating, but it is totally reversible. There's no evidence that it should affect your fertility long-term, right? And although if taken on its own, it would kind of yield menopausal side effects. What we do here is we give you a hormone add back each month. So in addition to having the injection of the GnRHa, which induces this temporary chemical menopausal state, you are also taking a hormone add back of estrogen and progesterone to kind of bring you up to just kind of this average premenopausal level so that you don't have some of those menopausal symptoms such as bone density loss or vaginal dryness or things like that, right? The idea is really to reverse those menopausal symptoms with the hormone add back. And finally, surgery. We do have a lengthier webinar on surgery. I see that that's linked here. That's something that you can certainly reference if that would be helpful as well. But the important thing to note with surgery is kind of once you've, I would say that temporary chemical menopause is often the step before. That's a way to kind of test out that you can tolerate that experience and tolerate kind of the hormone add back that comes if you're considering surgery for PMDD. I also want to note with temporary chemical menopause, I'm going to scroll back up to eliminate confusion. This is safe long-term as far as we know, right? This can be done for years. There's more accumulating evidence that it's a safe long-term treatment. Nevertheless, often for various reasons, people will opt to move from temporary chemical menopause to surgery. The surgery has to involve removal of both of your ovaries in order to be an effective treatment for PMDD. And often people will also opt to additionally have a hysterectomy. I want to note also, this is just like with temporary chemical menopause. This is once you've tried the other options and now this is kind of a final way to get that relief after trying some of those less invasive treatment options. What is PME? So PME is not yet in the Diagnostic and Statistical Manual for Mental Health Disorders, the DSM, or the ICD-10. So PME is premenstrual exacerbation of an underlying disorder. So whereas in PMDD, we see this kind of off-on pattern of symptoms, right? Where people go from having 0 symptoms to suddenly having this kind of surge of symptoms in the week to 2 weeks before menstrual bleeding. In PME, it's more likely that you have these, what it is that you have these symptoms all the time, and then they experience this kind of perimenstrual worsening, and then they kind of go back down to their baseline, to their normal levels by the end of menses. The time course we're seeing might be a little different. Sometimes we're seeing that With PME, maybe the symptoms start a little later and kind of return to baseline a little later than in PMDD. So as I said, PME refers to the premenstrual exacerbation or worsening of the symptoms of another disorder. It may be major depressive disorder or generalized anxiety disorder. And while this exacerbation can affect many conditions, for example, it's been noted in asthma and arthritis, IAPMD is focusing slowly on the exacerbation of psychiatric disorders. So as the first organization to focus on PMDD, we have come to realize the equally immense need to provide support and education and resources to all individuals living with premenstrual exacerbation, PME. So in addition to those suffering from PMDD, numerous studies and independent research have shown that as many as 49% of those self-diagnosed and medically diagnosed with PMDD may actually be living with PME of an underlying disorder. And we have a link here to read more and take a self-screen. So which disorders can be affected? Pretty much any mental health condition can be premenstrually exacerbated, including eating disorders, major depressive disorder, persistent depressive disorder or dysthymia, suicidality, schizophrenia, anxiety disorders, alcoholism, and many more. Do we know the cause of PME? We don't really know. We know as much, we know that it's a hormone sensitivity as it is in PMDD, right? We know that it's some hormone sensitivity in the brain. So it's once again has to do with this kind of abnormal brain reaction to normal changes in estrogen and progesterone across the cycle. But we don't know much more than that. I do want to quickly actually stay here for a sec and mention kind of what research is going on around PME. So going up first. So first I want to mention that there's research showing that addictive disorders certainly kind of can fluctuate over the course of the menstrual cycle, and they may show a primary or secondary worsening around ovulation as well, right? So they may have this premenstrual increase, but they also may have this worsening around ovulation when there's this surging estradiol, which increases your reward sensitivity, right? So for those who are maybe kind of relying on alcohol to increase positive emotions, right? This surge in estradiol that's associated with the increased reward sensitivity can make you more vulnerable to alcohol use around ovulation. There's also research investigating PME of bulimia, borderline personality disorder, obsessive compulsive disorder, ADHD, bipolar disorder, schizophrenia, and PTSD, post-traumatic stress disorder. For example, a longitudinal study in bipolar disorder demonstrated that patients with premenstrual exacerbation of bipolar can sometimes suffer a more severe and chronic course of illness. We referenced suicide. We referenced suicidality here as well. A large number of studies have indicated an increased risk of suicide attempt and death around menses. It's also important to note that not all people, just because this is kind of pervasive across pretty much any mental health disorder, doesn't mean that all people with a mental health disorder experience PME. Rather, it's more similar to what was observed, what we've seen in PME of depression, which is that risk for PME probably varies on a spectrum within a larger diagnostic group, right? So some people experience PME of their symptoms and others do not. But it does seem that PME is present in a lot of cases of psychopathology. For example, we know that 60% of ovulating people with depressive disorders experience PME of at least one symptom. Can PME be diagnosed yet? This is not an official specifier in the DSM yet. So at this point, it cannot be officially diagnosed, Nevertheless, if you're working with someone across any discipline, whether it's your general physician, a psychologist, psychiatrist, gynecologist, if they're knowledgeable, they will know what PME is, and they can at least you can still do daily ratings, and we can still understand your symptoms in the context of your menstrual cycle. We can still understand how your symptoms change across the menstrual cycle via daily ratings. And this can inform which treatment options may make the most sense for you, right? Maybe you need to be taking, maybe something like oral birth control is going to be important or what have you, right? But even if it can't be formally diagnosed at this point, you can still rate your symptoms and we can still detect a pattern. So I spoke to ongoing research. I do want to speak a bit more about this and just say that what's tricky with PME is that we think that some of the pathophysiology of PME may be different than in PMDD. So what we find is that many PMDD specific treatments are not as effective for PME. For example, drospirenone containing birth controls were recently evaluated as an adjunct to SSRIs for patients with PME of depression, and they failed to beat placebo. Right? And there's some studies showing that at least for premenstrual exacerbation of depression, even GnRHa injections might not work quite as well as they do for PMDD. So there's ongoing research to figure out kind of what are the best treatments for PME. There has not been a test showing differences in SSRI effectiveness between PME and PMDD. So we can remain somewhat optimistic that SSRIs would be an effective treatment for PME as well as PMDD. But more work is needed in this area to determine whether and how different treatments may be broadly effective in PME across various disorders. As I mentioned, no trials have examined the effect of SSRI or of psychotherapy such as CBT on PME of depression or on PME of other disorders. So this is also worth further investigation. There's going to need to be kind of ongoing research on some of these biological mechanisms because there's some research suggesting that what's likely happening in PME is that some people may be more sensitive to the withdrawal of hormones at a later point in the cycle, which is why kind of traditional methods that are more focused on hormone suppression may not be as effective. So we need to find kind of other interventions that may be more effective for those people. All right, Laura, I will turn it back over to you. Thank you all so much. I'm happy to answer questions. But it was so nice to talk to you all.
Wonderful. You're such a gem. Thank you. That was perfect. You covered so much. It was really, really wonderful. So what I'm just quickly going to do before we answer any questions, just a reminder that we can answer sort of general questions. So if you have any general questions about PMDD or PME, then please do ask them in the Q&A bar at the bottom. We can't answer questions related to your specific care and your specific circumstances. So just a really quick reminder, especially if you're here, I know 50% of people attending were here looking for information for other people, so this might be useful for you. If you haven't visited our website yet, it is absolutely packed with useful information for patients and providers alike. So please do take a visit. The search bar is your friend, I have to say. You will see the search bar at the top here. If you pop in there, pop any keywords in there, it not only searches the whole website, but it also searches our knowledge base as well, which I will explain in a moment for you. Okay. And if you are looking for any support, we offer free video support groups, email support. We have an Inspire forum, which is a non-social media form of getting support. So it's like a standalone forum that's available 24/7 and is moderated. And we run 7 support groups on Facebook, including one for parents. If there's any parents here today looking to get a bit of support for themselves, looking after a younger person going through that. And that can all be found on our website under the support tab, so do take a look. Wonderful. And I should say, so on the website as well, we have the toolkit, which is really useful. If you are looking for an overview sheet to take to your doctor, your provider, there's one there. We have appointment sheets, so you can write all your information out in advance to take to the doctor, what you tried so far, what your symptoms are, a bit of your medical history. And then we also have ongoing appointment sheets, so you can print one out for every appointment ongoing to take notes. Obviously symptom trackers, and we have an action plan and a crisis planning sheet there, along with a video to help you fill out your crisis plan. So again, for any parents or partners, as well as patients, that can be really useful to have in advance for peace of mind. Okay, so if you, like I said, if you need anything to pass to your doctors, I have just added in the chat. There's quite a few links in the chat. Sorry, I've been trying to get everything as we've gone along. I've updated a file of the provider guidelines, and on this page as well, you can also find lots of information for providers, provider resources. It's like a toolkit for them. Thank you. So we have a massive knowledge base now that's searchable on the website. Like I said, if you use that search function, it not only searches the website, but it searches everything on that knowledge base. It is packed full of information and answers to questions about premenstrual disorders, both PMDD, PME treatments, and about IA-PMD. So if you're ever looking for anything, it's a really, really good place to head. Go. And if you're just learning about PMDD and finding it a bit overwhelming and all the acronyms, we do have a glossary, because I know it's really hard when you first start, or even if you're further along in your journey, to sort of understand all these acronyms and new words and medications. So it's a really good place to head if you're get a bit confused or read something you don't fully understand. Go. And we are a non-profit, and please do donate to us today if you're able to do so. It just means that we can keep running more sessions like this to help more people, keeps our peer support running, and it really does help us. So I think if we just leave that slide up there, if that's okay, Dr. Ross, and we'll just answer a couple of questions. Oh, you're on mute. Come back.
I'm back. Yes, I've been typing answers to questions in the chat while we've been speaking. Would it be, let me finish my thought on one, and then should we kind of go through the rest as a group, or if anyone wants to
start answering one, if that's okay, while you do that, because I definitely know the answer. So a question about chemical menopause. You put chemical hysterectomy. I'm guessing you mean chemical menopause in the UK can only be used between 6 months and a year. Is that true? It used to be the case that it could only be used for 6 months. However, sort of as time has changed and moved on, you can use it long term as long as adequate HRT is used. So if you have adequate estrogen to protect your bones, lung and heart health, and also a progestin add back, I would suggest going to, I popped it in the chat, but on the website under the surgery section, we have a whole sort of resource on chemical menopause. And so if you have a look there, and it will answer a lot of your questions there. So I hope that helps.
Great. I'm seeing some other questions here. So we spoke.
Oh, sorry, yeah. I think I just deleted someone's. I'm very sorry if that was you. Do put it back.
I want to hop to one broad one about what about secondary effects of SSRIs or the effects of using them over a long time. By secondary effects, I'm assuming you mean like side effects. And that's absolutely a concern and really person dependent, right? There are a lot of unwanted side effects that can be associated with SSRIs not for everyone, right? Some lucky people end up with very few side effects while others experience a great many side effects, but low sex drive, night sweats, increased anxiety. These are some kind of side effects that people can experience, weight gain, right, from SSRIs. And I think it's really about evaluating. It's a very personal decision of evaluating pros and cons, right? Are you getting enough relief for the PMDD symptoms to justify the side effects or no, right? And I think that that's something that needs to be weighed very carefully with your provider. I think the other important thing to note there is that different SSRIs can affect you differently, right? You may have really unwanted side effects from one SSRI, and that may kind of discourage you and put you off from SSRIs altogether. But keep in mind, you may try another one where you have far fewer or even no side effects from the SSRI. So it's kind of worth some trial and error. With something like weight gain, I'm just throwing this out there, you didn't mention it specifically, but it can often be helpful. On average, there isn't evidence that people on average gain weight while taking an SSRI, but it's an average, right? So some people do. And with things like that, as long as you're kind of tracking while you're using it to figure out kind of, is this kind of happening systematically? Do I need to make a change, right? It's all about kind of monitoring throughout and weighing pros and cons with your prescriber. But in terms of beyond unwanted side effects, there shouldn't be any kind of known health risks or complications with taking an SSRI for a long period of time. So I think that's the second question. I see this one.
Thank you.
Yes. Do stimulants like amphetamine help with the anxiety aspect? I know this is an ADHD medicine. As far as I know, but keep in mind, I'm not a psychiatrist, but to my knowledge, an amphetamine could very possibly worsen your anxiety rather than helping. So often for people who have ADHD and anxiety, it would be kind of complicated even to prescribe an amphetamine because it can worsen the anxiety symptoms. So I wouldn't generally think of an amphetamine as the best treatment for the anxiety aspect. However, it may be that it's certain. We know that amphetamines are certainly effective for ADHD, and we know that there can be premenstrual exacerbation of ADHD symptoms. So that's when kind of considering how you kind of tinker with an amphetamine along with your prescriber may be an important discussion to have. And birth control Seasonique had severe side effects with me. Gynecologist said birth control for women over 40 is dangerous and won't prescribe, even though it seemed to be working for me. So I would say you can still be taking birth control over 40. I think it depends. You have to kind of evaluate if there are other kind of health risks here that I'm unaware of, then that it may be where the gynecologist is coming from. It really depends. And I don't know the specifics, but no, there are certainly birth controls that are safe for people to take above the age of 40. Yaz in particular does have some specific kind of no-go criteria. If you, for example, if you have any other kind of blood clotting risk factors, then they won't prescribe Yaz. So it could be that for some other reason, Yaz is not accessible to you. Kind of depends on the person.